Doctors Beggs and Parsons discuss the current status of gene therapies in rare neuromuscular disorders in this 8-part podcast series. This is derived from the symposium that was presented at the MDA 2025 conference in Dallas, Texas in March 2025 and is intended for healthcare professionals only. This podcast includes information about investigational compounds that do not yet have a regulatory approval or authorization for a specific indication. The safety and efficacy of the agents under investigation have not been established, and contents of this podcast shall not be used in any manner to directly or indirectly promote or sell the product for unapproved uses. The Aspiro clinical trial is on clinical hold since September 2021.
The views, thoughts, and opinions expressed in this presentation belong solely to the author and are subject to change without notice. The contents of this presentation do not constitute an endorsement of any product or indication by Astellas.
In this part, Dr. Parsons will discuss understanding and preparing risk factors associated with AAV gene therapies.
So now with our collective experience, we can at least put together the information that we have in terms of what can we expect and what's the timeline that we expect in terms of our patients having reactions. I will tell you, and I've said this multiple times, when I deliver a gene transfer therapy, I hold my breath for 2 months. Now maybe it's going to have to be extended to a year, but it's typically at least for 2 to 3 months. It's like, okay, what's going to happen? You sit on the edge of your seat on pins and needles going, is this kid going to be okay or not? And I think that's the appropriate response to have in terms of the light of things that have happened over time. So we have to be really careful. But we have a little bit of a framework now to say, when do we need to be really excited? So we know that our patients, most all of them, are going to develop a transaminitis, and that ends up happening early on, but we get a couple of peaks. We get really excited at the 4 to 8 week time point with transaminitis, looking for liver failure. The cholestatic liver disease that happened in the patients with X-linked MTM happened a little bit later, so week 2, all the way out to 6 months afterwards. The acute cardiomyopathy a little bit earlier, so we're looking a little bit earlier for that kind of effect. TMA, usually the end of the first week to about 2 weeks is when we would expect that to come in. And then the transgene-related myositis and immune-mediated myocarditis, weeks, maybe 2 to a couple months. So how do we adapt our gene transfer programs to the clinical trial experience? And I think that there are a couple of points that are important. One is that the outline that I showed you, there are some disease-agnostic issues that come up with transaminitis, with TMA. I think there's some final common pathways related to the immune responses that we see with these patients. But then there are going to be some disease-specific disorders that are going to come up with each of these therapies and agents. So we need to have good communication, honestly, in real time. I still don't know that we have a good mechanism for that as a community, but to share these adverse events that come up so that we can all learn as a collective about what to expect, what to anticipate, and how to best take care of our patients. We know now sort of how we need to monitor patients closely from a laboratory standpoint, from a clinical exam standpoint, and we really need to work on how are we going to mitigate some of these risk issues that we have with these patients. So I think the collaborative aspect, particularly at meetings like this, is important. Last year, for the people that were at MDA, you remember that we really spent a lot of time looking at gene transfer delivery. Many of us got together as providers and actually met together to say, is there something that we can think about in terms of best practice or consensus in terms of how we would want to manage patients or how we'd want to share information? And so now actually on the MDA website, we really do have some guidelines, and there will be a publication coming out shortly that will have this available to everybody. Again, it's not necessarily the right answer, but it's at least from a collective experience, what's the best way that we can go forward? Some of those suggestions were that the adverse events right now, we can put them into some kind of a predictable timeline, but we don't really know all the risks at the time of dosing. We know that gene transfer therapy can be safe for the right patient at the right time for the right disorder. That's really what we want to do. There's kind of a narrow therapeutic window between efficacy and toxicity, and how are we adjusting that? What are we working on to make sure that we're getting that right? The preclinical data is helpful, but it's never the full story. And anytime we go from a homogeneous population that we see in a clinical trial to a heterogeneous population, as we throw this out to the world, we're going to have new issues that arise, and we need to be aware and ready for those. So we want to be able to predict what happens, but we can't always do that. And then follow-up is so important. So the post-marketing studies, sharing adverse events, sharing experiences, I think is really important as well. So clinicians really should be familiar with this entire field before ever delivering gene transfer therapy. And I don't think that every site should be delivering gene transfer. I think that from an institutional standpoint, you need to be ready. You need to have a team who knows what they're doing and knows how to handle the issues and the problems, or you need to have lifelines set up in advance if you're going to deliver these treatments. So from a pre-infusion standpoint, there needs to be institutional readiness. There needs to be education of all the players that are involved. The family, the patient need to know what to look for, what is going on. And they have to know before they're treated that they need to follow up and what that follow-up is going to look like. Because very close follow-up for an extended period of time, certainly more frequent appointments early on. But as Alan said, we don't really know about durability yet, and so we need to follow these patients over time.
In the next part, Dr. Parsons will discuss changes in gene therapy programs and lessons learned from recent trials.